Hi, this is John Canelopoulos from a center here in Athens, Greece. We're going to see a quite interesting refractive surgery, I would say, case. This is a young gentleman in his 40s who underwent a cataract procedure for premature cataract. And as you can see here, he was treated with an EDOF lens. He came in with severe complaints of fluctuation of his vision. He had to wear a plus half lens. We can see the contrast-sensitivity. The right eye is not that great. His analysis of quality of vision, the H analyzer is poor. These are the topographies showing topographic astigmatism. There's slight epiretinal membrane, but the central macula is fine. In careful exam, we did reveal, as you can see here, that he has significant mapped out fingerprint, and this alone is a contraindication. He has it in both eyes for an EDOF lens, at least in my opinion. We can pick it up here as on the right side of the epithelial map, little peaks of epithelium. So after discussion with the patient, we went ahead to exchange the EDOF lens with a monofocal lens. We initially planned, since the procedure was 6 months ago, to use a toric lens. You can see the toric signs placed. This case, as most things in medicine, does hold a big surprise that I'll share with you. Viscoat in the anterior chamber. I'm trying to release the lens from the capsule. I'm doing a very good job. I'm expressing the lens in the anterior chamber. Soon to realize that the patient had a primarily posterior capsulorhexis that's so perfect, my heartbeat is raising here a little bit, that it was hidden within the round circles of this infinity lens. So bisect the lens in two, remove one piece, then the other. There's no vitreous in the wound, so probably the procedure done elsewhere was also accompanied by an anterior vitrectomy. I'm using IA to remove the viscoat. Obviously, the surgery plan has changed. I cannot use a toric lens. I do not have a lens that can be fixated in a sulcus. His lens, and this is kudos to the surgeon who performed the first surgery, this was outside Greece, was placed in the capsule bag. At this point, the capsule bag has contracted, and as I mentioned, he has a primary posterior capsulotomy, a little tongue of vitreous there that I'm releasing. So there is some residual vitreous left behind. So the decision here is made to do a manual vitrectomy of the very limited vitreous bands that are present. I'm getting busy with the WEC and the Westcott scissors in order to release these small bands and remove them from my wound. I'm going to reevaluate this after placing a three-piece sulcus lens. We'll go to the Alcon MA lens, which is our go-to lens. Of course, adjust the biometry accordingly. Since the lens will be placed in the sulcus, you're seeing here, I'm going in with the Kugel and hook, making sure there's capsule support 360 degrees. A little delay here as we're reconfiguring the IOL numbers, and the team, we can see it in the upper right corner, is busy in doing so. I'm coming in with my anterior vitrector to complete the vitrectomy. A key thing to the procedure, we do not want to have vitreous as part of our treatment here, so I'm pulling in the vitreous tags and releasing them with my vitrector. The 2-3 tags are not an issue anymore. Using epi to dilate the pupil, you can see how perfect this posterior primary capsulorhexis was. I'm going to use viscoelastic in the sulcus. Here's my MA lens, obviously subtracted one diopter since we're planning emetropia rather in this patient. Maybe slightly hyperopic as he's been used to wear a plus lens, probably due to it making him functionally attain meiosis through accommodation or pseudo-accommodation. He's pseudophakic. I enlarged my incision towards the 12 o'clock position in order to treat some of the cornea astigmatism and my incision is a little bit larger than normal for the main lens. I'm orienting the lens in a placement where the haptics give very good support. Acetylcholine to attain meiosis. We have no vitreous prolapse. The wound is watertight without a suture, and our procedure is all done here. And we replaced the EDOF lens with the monofocal lens. We were not able to address the astigmatism. This is the eye. He's 2016, uncorrected. He does still have fluctuation in his vision because of his anterior basement membrane dystrophy. And here we're seeing a morning picture where the phenomena is worse. The epithelial maps on the right, the PTK maps showing the residual astigmatism, and we're going to address this in a PTK procedure. These are the ray tracing imaging maps, but remember these also carry bias from the regular epithelium. These are the reflection topography images, again confirming the irregularity that comes along with ABMdystrophy. This is the refraction of the right eye. We opted to treat the left eye as well, which also had ABMdystrophy, a developing cataract. So we went ahead and split, since we wanted to treat the large area of the cornea surface, his refraction into a myopic and a hyperopic refraction. This way, we're able to treat a very large area of the cornea surface to reduce the ABMdystrophy. And this is the video of the procedure. We're seeing here the ABMdystrophy. It's obvious. I'm cleaning with the Orca instrument, and you'll see that I'll have to use a blunt crescent blade as well to remove the scarring to reach Bowman's membrane, which we will treat then with the sequential myopic astigmatic treatment and the quote-unquote hyperopic treatment, which is seen here. And I'm also roughing out the Bowman's membrane outside the area that I've treated in order to attain the advantage of better epithelial healing and reduction of the ABMdystrophy. So the bandage lens is on, and here the before and after, and the difference, we're seeing how smoother the central sign fluke imaging of the cornea is. The other eye as well has improved. There's less of that shake imaging that we're seeing on the left and the middle, and the difference. And we're seeing the right eye here. Eventually, again, 12 vision, pristine cornea, no ABMdystrophy, and we're obviously seeing the improvement in the contrast sensitivity maps that we're going to see in the end. So this is again a story how we had to take the lens out, put a new lens in, but also treat an underlying cornea disease. This is John Canelopoulos. Hope you found this interesting. Signing out. Thanks so much for your attention.